Okay, let's go.
Today, I want to talk to you about enhanced recovery after surgery pathways. Enhanced recovery pathways after surgery protocols and guidelines came about roughly about 25 years ago when they were first developed by a group of experts and published for the surgical community to see and to use for their patients. Acceptance and utilization of enhanced recovery pathways, despite the fact that they're 25 years old, has been very slow by the surgical community. In fact, it is only now that there are a lot of research studies coming out showing how impactful and powerful these pathways and protocols are to help improve the patient's pain experience and also help them recover from surgery. So let's get into it. What is enhanced recovery after surgery pathways? Well, it starts actually when you first meet a patient, and the first and most important part of enhanced recovery after surgery is spending time with patients to educate them about what they can experience after surgery with respect to their pain. And one of the most important things for patients to understand is that pain is part of the game of surgery. And when anybody has surgery, they are going to feel the surgery. They're going to feel some soreness after surgery. So the question is not whether you're going to feel pain after surgery. The important question is, how much pain do you have? And in general, we are trying to control your pain to a level where you can have function, mobility, basic level, without giving you so much medications or such strong medications that knock you out after surgery. Unfortunately, a lot of patients are not educated about what is proper pain control. And so many patients feel that after surgery, they should not have any pain. And that's just not accurate. Most patients will experience some level of pain and soreness, but our job as surgeons and the surgical team is to keep that pain level to a point where you can resume most of your normal activities, such as walking, going up and down the stairs, taking showers, and yes, within 2 to 3 days, even driving. People have asked if sexual activities is included, and I always say that it is included in the types of activities that you can be doing shortly after surgery. But again, the expectation is very important to be placed at a level that is reasonable. And you can't do that if you don't engage patients about what they can expect after surgery with respect to the pain. We have historically, in the medical community, done a poor job of not only talking about pain, but managing the patient's pain after surgery, which is fortunately now changing given all that's happened with opioids and overprescriptions. Modern practices, such as ours, will always talk to you about enhanced recovery after surgery pathways and how we're aiming to reduce your exposure to opioids, which are frequently not needed. And we'll dive into more of what we do. But all of this starts with very good education and discussion with patients as part of really the first initial consultation when we determine that a patient needs surgery. Once that conversation is had, the patient's expectations begin to be more reasonable and within line of what we want to achieve around the time of surgery. Again, we want to keep the pain down to a level where patients are mobile and able to move around and are not passed out in a corner of a room, or nauseous or constipated or unable to take the pain meds because they're too strong for them. The second part of enhanced recovery pathways after surgery is actual implementation. And that generally starts on the day of surgery in the pre-operative area, where you meet with the surgeon, with the nurses and anesthesiologists before you go back. There are a set of medications that will be given to you to start having some of these agents in your system. And these medications are not opioids, specifically Tylenol. We usually give about 1,000 milligrams once, gabapentin, about 900 milligrams once, Celebrex, about 200 milligrams once. And then that begins the cocktail that goes into your body and prepares it for surgery. In my practice, as soon as the patient goes to sleep, there's another medication that's given that's the equivalent of ibuprofen IV. That's called Toradol. It is not an opioid, but it is a powerful agent that helps to immediately get into the patient's system and prepare them for surgery. Again, all of these medications are given before any incision is made on the patient to help prepare their body and to have something on board so that when we begin the surgery, they experience less pain. And because they're experiencing less pain, our anesthesiologists can also reduce the amount of opioids that they put in the anesthetic. Once we begin the procedure, the first part of most of my surgeries, especially abdominal surgeries, but any kind of surgery, is we do an additional block in the region that we're operating. So we take a mixture of lidocaine and marcaine and inject the abdominal wall in specific areas that knock out the sensory nerves that allow the patient to feel pain. It is not perfect in terms of reducing the patient's sensation of surgery on their abdominal wall, specifically the incisions, but it is very powerful in helping combine with other modalities and other interventions to reduce the patient's pain experience and improve what they feel and how they recover. And generally, we like to endorse minimally invasive surgery as part of enhanced recovery pathways. As much as possible, we try to avoid large incisions when appropriate. Using robotics or laparoscopy helps the patient to have less pain after surgery. Once our camera is placed into the patient's abdomen, we can then proceed to, under direct camera view, inject the abdominal wall and essentially numb those nerves that can sense pain before we start the surgery itself. That process takes about 5 minutes at the beginning of every surgery, that we take our time and we make sure that we completely block the nerves or the sensory nerves in the regions that we're operating. And once that is done, then we proceed to actually start the surgery. From the time that we've met the patient until we actually start the surgery, we have had multiple interventions, starting with the patient's education, setting the expectation so the patient is psychologically prepared for what they are going to experience, because that means they're going to feel not as bad when they know that soreness is a normal part of recovery, followed by actual medical interventions that are often non-opioid, that are not going to make patients groggy or nauseous before surgery, and immediately at the start of surgery once surgery begins. Once the surgery is complete, at the very end of surgery, we make sure that every patient leaves the operating room, especially if it's an abdominal wall surgery where we've gone inside the abdomen and either done GI surgeries or hernia surgeries, and given an abdominal wall binder. Can wrap around the abdomen and you can essentially tighten it around the abdomen. And as the patient wakes up, they have another layer of essentially protection against the abdominal wall that holds things together tight, especially as they get up and start moving. So gravity does not cause them that discomfort that many patients can feel immediately after surgery when they're up and try to first move or walk. As the patient makes their way into the recovery area, where they usually spend about an hour or so to recover from anesthesia and prepare to go to home, we don't find that we generally have to give any additional medications, because at this time, the patient has already received multiple medications, most of which are non-opioids. They have enough interventions to wake up from surgery feeling like something was done, feeling soreness, but not being in extreme pain. Now, I was talking about how the impact of these interventions help our anesthesiologists in how they not only put you to sleep during surgery, but which kinds of medications they give in that mixture. And as I mentioned, the enhanced recovery pathways allows our anesthesiologists to not have to give you as much opioids in their anesthetic, which means that as you wake up from surgery in the recovery area, you not only wake up faster, but you wake up with less nausea, less vomiting, and it means you can actually recover faster and go home faster. And when you go home faster, you continue to benefit because of the lack of opioids or minimal opioids that were given, so that you're not nauseous at home, you're not as foggy, you're not passed out on the couch somewhere. You're essentially up and able to move around as soon as possible within an hour after surgery. When patients go home, they can't go home without pain medications. And historically, what surgeons used to do was they used to write for a very large dose of opioids. They would write for 30, 40, 50 tablets of, let's say, oxycodone, which was a very favorite thing. Percocet was one of those medications. And back in the day, it was very common for patients to receive a large bottle of those medications to take home with them. Now, majority of patients, of course, did not end up taking all of those medications, but the problem was that a lot of those medications ended up on the shelf, and so other people had access to them, including potentially children, teenagers, and other folks that have not only access to them, but potentially abuse them. So it was very, very dangerous to prescribe those types of medications. What most patients actually ended up reporting back was that they couldn't take those medications because it was too strong for them, and it would cause them to have nausea, it would cause them to have vomiting, it would cause them to have constipation. They felt foggy and they couldn't move, and they just felt like they had to just sit on the couch or lay on a bed the whole day. As enhanced recovery pathways came into the picture, it allowed surgeons that were practicing modern medicine to implement those pathways. Surgeons could send their patients home with over-the-counter medications such as Tylenol and ibuprofen, which were not only beneficial, you could take those together, but it would allow the patients to be able to take their pain medications, help control their pain so they would have better experience and not feel like they are nauseous, groggy, vomiting, or any of those things that are very common with opioids. In our practice, when our patients go home, they go home with over-the-counter Tylenol, usually 650 milligrams every 6 hours, because we want medications in your system at all times so that you're not waiting for pain and then trying to treat it, taking a tablet and waiting now for 30, 40 minutes for that tablet to kick in. When you know you're going to be sore after surgery, we recommend to patients and we instruct patients, I instruct my patients, I want you to take your pain medications because again, they're not going to stop you from driving, they're not going to make you nauseous, they're not going to make you groggy, but they are going to give you that critical pain control that I need for you to be able to be mobile. The second medication that the patients receive, if they're a candidate and if there's no contraindications, is ibuprofen, 800 milligrams every 8 hours. You can get it from the pharmacist, and if they don't have 800 milligrams, you can take a couple of the 400 milligrams, or you can take 3 or 4 of the 200 milligrams, but essentially that medication can also be taken every 8 hours, and together the Tylenol and ibuprofen work to keep patients' pain under control. And this has really worked well for many of our patients. In fact, we published a study which showed that about 89 to 90+% of our patients did not require opioids after major surgeries, going in robotically or laparoscopically and doing hernia repairs or doing GI resections and so forth. Patients also go home with their binder, and we usually recommend that they wear their binder during the day for the first week after surgery. In general, your pain after surgery will be the worst in the first 3 days, followed by more soreness in the coming days after that. But during that first week to 2 weeks, that's the critical recovery area or time when patients' pain can be, let's say, the worst. And when I say the worst, it does not mean patients are bedridden or crying, but it means that the soreness is the strongest it is. So you can imagine you can do these major surgeries, usually discharge the patient home the same day, and keep them off of opioids as long as, number one, you recruit the patient, we recruit you as our partners, so you're fully educated, understand the entire pathway, why we do it, how we do it, and also we always have our bailout, meaning that if we do all of these interventions and our patients call us back or they're having severe pain to the point that they can't move, we usually go to the third medication, which is tramadol. Tramadol is a light opioid. It's not as strong as oxycodone or Dilaudid, and it often works as the third agent you can take along with Tylenol, along with ibuprofen around the clock. The tramadol is taken usually 50 milligrams every 6 hours or so as needed for breakthrough pain. And that usually is where we stop. It is very rare for me in a year's time to write for medications such as oxycodone. This is an incredibly important care pathway, and it's just one of many examples of care pathways that we combine with modern technology to ensure that you get the best experience at every phase of your care. I hope you found this video informative, and if you or any of your loved ones need surgery, please come and see us. We'd love to take great care of you.
Okay, let's go.
As always, God bless. Thank you.